Hi, my name is Alana and this is my health assessment final practical. The first thing I'm going to do when I enter the room is I'm going to wash my hands thoroughly for at least 30 seconds. The next thing I'm going to do is I'm going to put on PPE, which in this case would be gloves because I'm doing a physical assessment. If the patient had any kind of precautions, I'd put on the appropriate PPE, which could be a mask or a gown. Now I'm going to close the curtain for patient privacy, and I'm going to introduce myself to the patient. Hi, my name is Alana, and I'm your student nurse today. What is your name?
Camilla.
Where are you right now?
In the hospital.
And what year is it?
2020.
Great. From that information, I can tell that my patient is awake, alert, and oriented ×3, and now to the time, person, and place. And now I'm going to ask her a few questions. Do you have any allergies?
No.
Do you have a past medical history?
No.
Do you drink, smoke, or do any drugs?
No.
Do you take any medications?
No.
Do you exercise at all?
No.
Do you find yourself to be an overall healthy person?
Yeah.
Great. Now I'm going to ask for permission to do the assessment. So I'm going to be performing a head-to-toe assessment on you, which will involve me touching and looking at your body. Is that okay with you?
Yeah.
Great. So now I'm going to start with the head and neck part of the assessment. I'm going to start out by looking at her eyes. So I'm going to shine using my pen light. I'm going to shine it in one eye. I'm going to look for direct constriction, and I'm going to shine it in that same eye again. And I'm going to look for consensual constriction in the other eye. I would do that on both eyes. And then I would have the patient look far away in the distance, and I have her follow my pen light in, looking for both eyes to constrict and converge, which they do. And her eyes also her pupils are equal, round, reactive to light, and accommodate, which is normal. Now I'm going to look at her sclera. The sclera should be white and clear, and I'm going to look at her conjunctiva, which should be pink and moist. Now I'm going to have her open her mouth, and I'll look at her mucous membranes. Also pink and moist, which is normal. Now I'm going to assess for her trachea, which is midline, which is a normal finding. And I'm going to take her carotid pulses on both sides for 60 seconds, but one at a time. I would expect for the pulse to be between 60 and 100 beats per minute, and I'd expect it to be a +2 on the grading scale. Now I'm going to assess for cranial nerve number 11, and I'm going to have her turn her head side to side with resistance and shrug her shoulders. Great. Now I'm going to move on to the respiratory part of the assessment, which is going to start with inspection. So I'm going to have her stand up. I'm going to look at the anterior and posterior and transverse diameter. So this is anterior to posterior, and I'd expect that to be a 1:2 ratio with her transverse diameter, which she has. And if it was a 1:1 ratio, it would be indicative of barrel chest and COPD. Now I'm going to look at her. I'm going to watch her respiratory rate without her known, so that her breathing is regular. So I'm going to look to see, I'm going to count her respiratory rate, and it should be between 12 and 20, and I'm going to look for any use of accessory muscles, which would be intercostals or any chest muscles. I'm also going to look for equal chest rise and at her skin color to make sure it's congruent with her ethnicity and not showing any cyanosis. And now I'm going to move on to the palpation. So for palpation, I'm going to look for symmetrical chest expansion. I would also want her respiratory rate for her chest rise to be equal. Now I'm going to do palpation for symmetrical chest expansion. So I'm going to have you take a deep breath in and out. Great. And I'm looking for my hands to raise equally in the same amount, which they did. If one was greater than the other, it would be indicative of some kind of lung obstruction or fluid. Now I'm going to move on to tactile firmness, which I'm going to have the patient say 99 while I feel for vibration with the ulnar surfaces of my hands. Can you say 99?
99.
Yeah.
99. 99. 99.
Great. And that was normal. If I find any kind of increased vibration, it could be indicative of fluid, and a decreased vibration, it could be an obstruction. Now I'm going to move on to percussion using the posterior approach. I'm going to start at the apices of the lungs, and I'm going to avoid the scapulus. I'm listening to hear resonance. Great. And now I'm going to discuss a little bit about diaphragmatic excursion, which in this case, I'm going to have the patient take a deep breath in and hold her breath, and I'm going to go down. I'm going to percuss down from when I hear resonance to dullness. When I hear dullness, I'm going to make a mark, and then I'm going to have her take a few normal breaths, and then I would have the patient take a deep breath out and hold, and I would percuss up from the line, and when I heard from dullness to resonance, I would make a mark, and it should be between 3 and 5 centimeters. Next, I'm going to auscultate for the bronchial sounds, in which it should be on either side of the trachea, and I should hear expiration greater than inspiration. And now we'll listen to the bronchiovesicular sounds, which I would listen to on the back of the patient. Can you stand up? And here I'm listening for them to sound the inspiration and expiration to be equal. And this is on either side of the spine. Now I'm going to listen for the vesicular sounds, in which inspiration would be greater than expiration, and that's going to be on the sides. So I'm going to have the patient raise her arm. Okay, great. And now I would also assess for bronchophony. So I would have the patient, turn around so I can see her back, and I would have the patient say 99.
99, 99, 99, 99.
Okay, and with 99, I would expect to hear a muffled sound, and if it was clear or very loud, then that would be an abnormal finding indicative of fluid. Now I'm going to start with the cardiac assessment, which I'd start with inspection. So I'm going to have the patient lay down. I'm going to assess for JVD. I'm going to inspect for JVD. So I have the patient at a 30-degree angle, and I'm going to look for any bounding of the jugular vein. And at the highest point, I'm going to measure that with a ruler, and I'm going to have the other ruler at her angle of Lewis, and I'm going to have that at a 90-degree angle, and anything less than 3 is normal, greater than 3 is abnormal, and if it was abnormal, I would also look at the hepatojugular reflex. Next, I'm going to palpate the chest wall, and I'm looking for any heaves or lifts or thrills, so I would go across, standing on the right side of the patient. Great. And everything felt normal, and now I'm going to auscultate. I'm going to be listening for at each of the valves. So first, I'm going to listen at the aortic valve, which would be on the right side at the second intercostal space. And that would be an S2 heart sound. And now I'm going to listen for the pulmonic valve, which would be also an S2 sound on the right side, on the left side, at the second intercostal space. Next, I'm going to move down a little bit to the tricuspid valve, which would be an S1 sound, which is at the third intercostal space. And then I'll move on to the aortic, which should be the point of maximum impulse, and that would be in the fourth or fifth intercostal space, mid-clavicular line on the left side. And that would be S1. Any additional heart sounds I may hear, I could hear an S3 or an S4, which would be pathological or physiological, and I would have to investigate further. I would use the bell of my stethoscope in order to listen to those and murmurs. Next, I'm going to move on to I'm going to listen to the carotid artery for bruits. So I would use the bell of my stethoscope. And everything's normal. So now I'm going to move on to the abdomen. So I'm going to start with inspection. I'm going to look for color, size, contour, and make sure everything's normal there. Then I would move on to auscultating, because you have to listen before you palpate, because you don't want to cause any abnormal sounds. So I'm going to listen using a systematic approach at the right lower quadrant first, where the ileocecal valve is. So I listen here for 5 to 30 bowel sounds per minute. And if I heard no bowel sounds at all, I'd have to listen for 5 minutes. And if I still didn't hear anything, I'd have to talk to the provider. And then I go to the right upper quadrant, and then the left upper quadrant, and then the left lower quadrant, listening for sounds. Next, I'm going to percuss, and here I'm going to be listening for tympany, unless I'm over an organ, which would be dull. I'm using the same systematic approach. Great. And now I can move on to percussion for palpation. So to palpate, I'm going to ask first, do you have any tenderness? Because you don't want to irritate that area more. So first, I'm going to ask, do you have any pain?
No.
Okay. Now I'm going to do light palpation first. So this is only 1 to 3 centimeters. I'm feeling for any pain or tenderness, or any abnormal bumps. Great. So none there. I would also progress to deep palpation as well, if that was to investigate further for organs. Now I'm going to move on to the upper extremity. So first I'm going to inspect for color. Well, I'll have the patient stand up, please. So the upper extremity, I'm going to inspect first. So I'm going to be looking for color to be congruent with her ethnicity, and I'm going to look for skin turgor and any alterations. I would also look at the profile sign for clubbing in her fingers, so the angle should be less than 160 degrees. I could also assess for her capillary refill, which should be less than 3 seconds, which it is. And now I'm going to palpate. So she feels, with the back of my hand, she feels warm and dry, which is normal, and smooth. I already did capillary refill, which would be part of palpation. And I'm going to perform range of motion and strength tests after I do the lower extremity. For the lower extremity, I'm going to look for the same things. I'm going to look for color, turgor, any alterations in the skins, also varicose veins. I'm also going to palpate. So for the upper extremity, I would take the radial pulse to see a distal pulse, because that would mean there were pulses anywhere more proximal, and that would be the same. I'd be looking for 60 to 100 beats per minute with a 2+ grading. And in the lower extremity, I would do the pedal pulse and the same things I'm looking for. So I would also test for temperature and the way the skin looks, as well as capillary refill on the toes. So now I'm going to have the patient just walk a little bit for me so I can assess for balance. And so I'm going to have her walk from here to there and then back, and I'm examining her gait. That was heel to toe, and I'm going to have her walk regular. Great. So I had her do both. I'm assessing for her balance and just any kind of instability in general. And now I'm going to do a little bit of range of motion with her to test her range. So the first thing I'm going to have you do is I'm going to have you with your head regular, that's extension. With bend your head forward, that's flexion. Bend your head back, that's hyperextension. Next I'm going to do lateral bends, so lateral bend left, lateral bend right, and then I'm going to rotate to the left and rotate to the right. Great, that's normal. Next I'm going to move on to the thoracic and lumbar spine. So I'm going to have, this is regular extension. I'm going to have you lean forward, bend forward, flexion, extend back as far as you can, hyperextension. And as side bend to the left, and side bend to the right, rotate to the left, and rotate to the right. Next, we're going to move on to the shoulders. So for the shoulders, I'm going to have you bring your arms up and forward. That's flexion. Back is extension. Next is abduction would be away, so with both arms away. You're good. And now back down. And then adduction would be crossing midline. Great. External rotation would be hands behind your head. Internal rotation behind your back. Yep. And the next thing we're going to do is we're going to assess the elbow. So I'm going to have the patient put their hands out forward, supinated, flip to pronated. Then I'm going to have them flex elbows, extend elbows. Great. Now wrists, flip your hands over. I'm going to have you, this is extension, up is hyperextension, down is flexion. Now for the hand, the fingers, I'm going to flex the fingers, make a fist, extend them, and then we're going to do abduction, which is fingers out, and then adduction, fingers in. Great. And hands out to the sides, ulnar deviation, hands in, radial deviation. Great. And now I'm just going to test her strength in her upper extremity. So I'm going to have you squeeze my hands. Great. And I'm going to have you open your fingers against my resistance. Great. And now we're going to move on to the lower extremity. For the lower extremity, I'm going to have you flex your leg straight out. And I'm going to put your leg back down, flex it with your knee bent. Great. Now we can do extension is normal, and you can hyperextend back. And then there's external rotation where you're going to put your knee out. You do this on both sides. And then internal rotation is in. Great. And now we're going to move on to the feet, and we're going to plantar flex is down, point down to the ground. Great. And then dorsiflex, which is up. Great. And you're going to invert, which is pinky down, your foot, and we're gonna evert, which is big toe down. Great. We're gonna abduct, which is leg out to the side, and adduct, which is leg crossing midline, and both sides. So now I'm gonna test your strength. I'm gonna have you raise your leg against resistance. Great. And for the toes, we would demonstrate it on the hands just for the sake of this. So we're gonna put your hands out and bend your fingers in, that's flexion. Extend your toes out, extension, and then adduction. Abduction is when you spread your toes, fan your toes, and adduction is when you bring them back in. Great. And now I'm gonna ask if she has any genitourinary issues. So, do you have any difficulty urinating?
No.
Any pain with urination?
No.
Great. Now I'm going to move on to some patient education. So I'm going to talk a little bit today about skin cancer prevention. You can sit.
Thank you.
So for skin cancer prevention, it's really important that you wear sunscreen. So one way that you can make sure that you have an appropriate amount of sunscreen on is to reapply every hour and reapply after sweating or swimming. You can also wear clothing that protects your skin from the sun, which is very important. And checking the UV levels on the weather app can be very helpful to predict how much sunscreen you may need. I would also perform monthly skin checks. Just look at your own skin for any kind of, bumps or marks or freckles that look abnormal or new. And you can visit a dermatologist with any concerns.
Thank you.
And now I would write down any abnormal findings, and that would conclude the exam. So thank you for being here, and I'm gonna leave the room now, but first I'm gonna wash my hands thoroughly again.